Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a special honor for me to introduce Dr. Tim Walker, DDS, MS. Tim graduated from Creighton University School of Dentistry in 1985, and from 1990 to 1995, he served as a dental officer in the U.S. Navy. He practiced dentistry privately from 1995 to 2009. Then he had a residency in the University of Texas Health Science Center, San Antonio, Oral Maxillofacial Radiology, which is OMR program. In 2012, graduated with a certificate in OMR and MS degree. Since 2012, he's held full-time faculty position at Creighton and also has a private practice in OMR. Dr. Tim Walker, thanks for being on the show today. And why don't you give the listeners a little bit of background about some of your profession in dentistry here?
Well, thank you, Phil, for having me in the first place. I practiced general dentistry for quite some time, and with that, I had a focus on TMD and occlusion, and my interests were heading that way. And with the advent of cone beam, in particular, my interest just kept growing in the radiology arena, and it was time to make some business decisions. And long story short, sold the practice and decided to head back to a residency. And I haven't looked back. It's been a wonderful choice, and having a good time. It's an exciting arena right now.
Well, that's great. I think having some experience before going back and getting any level of specialty training gives you a broader view on the field of dentistry. So I think it's great that you've got that.
Yeah, and I would agree. I mean, it was interesting there that when you work with the residents that just went straight from dental school into residency versus the residents that have been out in practice. There's pros and cons to both, and so I think the mix is important because we both look at the same thing quite differently.
It's all a matter of perspective, isn't it?
Yes, it is. Yes, it is. I mean, it's just like with you and in your restorative practices, you look at the same thing differently, and neither one's necessarily right or wrong. It's a different approach to the same thing. Now
that you are back in the academic arena, what is the main bulk of your time doing at Creighton University?
Well, we're principally geared towards the undergraduate level of dentistry, and so my primary focus is teaching dental students basic intraoral, extraoral radiography and interpretation. Obviously, with the advent of cone beam, we're in the process of trying to incorporate it more into the curriculum, but as everybody knows, our level of information in dentistry has continued to grow, but the time frame in which we have to teach it has remained the same. So it becomes complex. And where do you find the time to keep adding more and more information? And what information is it that you take remove from the curriculum in order to do that? How do you adjust it? So it's a very dynamic time in dental education. It's not just in the radiology. I mean, obviously you got the CAD/CAM stuff going on and changing quite substantially, and then the advent of implants and all the components that go along with that. And so what is it that the basic dental school graduate needs? What's that foundation that they need when they graduate?
Yeah, and that's ever changing in these fast times. Now, I graduated dental school in 2009, and I feel like back then there was very to little touch on the cone beam. It was an introduction to, there's this fancy machine and it can take 3D images, but we don't get any exposure to that, and we didn't get any training to that. So I feel like upon graduation, I knew quite a bit about traditional imaging, a little bit less about panoramic radiology than I maybe wanted to, and very little to none about cone beam, and that's just based upon the exposure I got in dental school and the amount of time that we had to present it and all of those things. So all of that kind of came through experience and extra level training. But I think you touched it. There's just not time for that.
Well, that's a big part of it. I mean, the basic radiology that the vast majority of the practitioners need involve intraoral and extraoral with the panoramic. The cone beam has its place without question, but is that going to be a primary mode of imaging, or is that going to replace extraoral or intraoral? And I would argue to no, that it will not replace it. And the reason is, the physics principally that are involved in CT technology. It's very, very different than the intraoral, although both still use ionizing radiation. The way the image is constructed is quite different. And as such, it has some pluses as well as some minuses. But for basic radiography, cone beam is not the choice. Intraoral or some of the extraoral and some of the new changes that are taking place in panoramic are your go-to modalities by far.
Sure. Now let's just start with a little general dentistry here. What are the most common mistakes you think being done out there for dental offices as it relates to radiology of just a general dental practice? What are some take-homes that you think you could help people with just in their day-to-day bread and butter dental practices?
Well, most of them are going to digital imaging, whether that's with the computed radiography or phosphor plates, and then the direct sensors. I think that switching to a long cone technique, because so many people are using XCP, is very important. Ironically, XCP is an acronym for extended cone paralleling, and oftentimes practitioners are trying to take images with the XCP using a short cone technique. So the geometry is not there. The other thing that's quite important, particularly with the direct sensor, the hard sensor, is you need a DC powered X-ray generator. If you're using an old AC powered generator with impulses, you can't possibly have the latitude that you need for your exposure settings. It's not there. So the images are going to be compromised because of that. So that would be you need to upgrade your machine, your generator, as well as your sensors. And the phosphor plates give you a little more latitude, and they have some strong pluses to them. Much more flexible, much more easy to use on the patients overall, particularly if you're doing any pediatric dentistry. The phosphor plates are substantially easier to use than the direct sensor.
So kind of having using a long cone technique with a short cone is probably one of the bigger problems, because I think almost all the new sensors or all the new tubes now are all short.
Yeah, most of the machines come with a short tube, and so you have to add that extra. And there's some that may not even be able to swap the cones. I don't know. That would be a manufacturer deal, but that's something to look at or talk to your supplier equipment rep to find out whether or not you could switch to a long cone. But it will make everybody's life easier. And the importance is, the direct sensor in particular is 20-25% smaller on average than film or the phosphor plates, and as a result, it's difficult to get a good parallel image on those sensors when you look at the average length of the tooth versus the average width or height of the sensor. So paying attention to that geometry is important. And then adjusting your exposures per the machine requirements and the sensor requirements. So it's not one size fits all for every patient that comes in, even with maxillary posterior versus mandibular anterior. Your exposure settings should change. And with the direct sensor in particular, it's quite important because you can underexpose or overexpose your image. And that brings me to another one I just thought of, that if you're going to err on exposure settings with digital imaging, you want to underexpose versus overexpose, because the data is there in the software, and it can be brought out. But if you overexpose, the data is gone, and you are not going to be able to bring it back. So if you're going to fudge it underexposing versus overexposing, and then use your software to bring out the nuances of the image.
Yeah, that's a great advice there. Now, what's been your exposure and or opinion of these new handheld units like a Nomad or a Max-Ray?
Well, I know there were some of them. You got to be pretty cautious on some of them. My understanding is that not all of them are approved in the U.S. I know the Nomad is, and we use them. I think I'm probably a little bit biased. I think that the Nomad has its place in an office, but I have some trouble with it being a replacement for a wall-mounted unit. Number one, it's 60 kV and about 2.5 MA, whereas a wall-mounted unit we're using at the school currently 70 kV and 6 MA. So, the exposure parameters are quite different. The other thing is when you're properly using the Nomad, the safety ring is supposed to be out at the end of the tube. And it's definitely a short cone technique. Well, it's difficult. You're going to have another aiming device other than the XCP, because the rod, the ring will be in the way of the rod of the XCP unit. So you'll have to modify things, or Rebex may make a unit for using it, but it's a different technique. I'm just not a big fan of swapping it for a wall-mounted unit. If you're in a surgery, I think it'd be hard-pressed to beat it in a lot of respects. If you need a quick emergency and you need a quick PA to see what's going on, I think it has its place. So if you don't want to equip every operatory with a wall-mounted unit, then I think the handhelds are a good adjunct. But I don't believe that they're a replacement. That's my own personal bias.
I'd have to agree with you on that. I think they're a decent adjunct, but I definitely prefer the wall mount, and would have to agree with you on that too.
I think too, for the staff, going back to it's to properly aim it. It's supposed to be parallel to the floor, and when you talk to the staff after a full day, their arms are tired, and then. So trying to hold that steady and everything for a full day, I think is going to be challenging for some staff members as well. So I think that has to play into the situation.
Now, speaking of staff, why don't we go into two topics that I think every general dental office could have a brush up on when it comes to digital radiography. Let's just assume that right now, since one, that's what I use, and two, like you said, it's heading that way. Talk to me about staff exposure and dentist exposure and lead apron use on the patients, and what you're seeing recommended, and what trends are, and what's really needed.
Well, that's a delicate subject. I mean, because you've got science involved and you got emotion involved. From a purely technical point of view, if you're using rectangular collimation and direct sensors, there's some discussion as to whether the lead apron really needs to be used. And from a purely technical point of view, I'm not certain that it does. But people are used to it. Patients somewhat expect it. I would probably use it on a routine basis in my office. I know that we do in the school, simply because they're used to it and it's not going to do any harm. All right. So, and it gives people peace of mind. For the staff, as long as they're minimum 3 feet, but at least 6 feet away, which is most of the requirements now for the exposures, they're going to be just fine. If it wasn't, we wouldn't be able to have the open bay concepts with X-ray generators being able to swing between operatories. So, our beam is very, very well collimated. Our throw is about 3.5 inches. So we're not dealing with the kind of power, if you will, that you would need, for instance, in a chest X-ray. It's, our surface area isn't that large. The bone density and thickness, overall anatomical thickness, is not the same. So, we're very blessed in dentistry, and I think for the most part that we've done a pretty good job of minimizing exposure to our patients and our staff. And I think it's something that dentistry should be proud of, quite frankly. So I think we've done well. I think we got room for improvement, but
I don't think anyone's, there's not too many dentists dying from X-ray radiation anymore, like there maybe once was in the early conception days.
Yeah, and I think that if we pay attention to the new the ADA guidelines that came in, I think it was 2012, and not doing the routine X-rays that were prevalent years ago, I think we're going to, and the insurance companies, I think, are pushing that to a certain extent with regards to the reimbursements. I think we're going to be just fine, and the guidelines that were written in such a way as to give the practitioner latitude to use their judgment on whether they feel it's appropriate or not to be taken the radiographs that they do. So. And I think that's a good thing. I don't think you can come up with hard and fast, well-defined parameters because our patients don't fit well-defined parameters. Life
doesn't always fit in nice, easy little buckets to put things in, does it?
No, it does not.
Now, I'm going to give you three kind of time frames here, getting back to implants. So let's say there's let's say there's like a pre-prosthetic or surgical implant imaging. There's the intra-surgical and during the procedure imaging, and then there's the post-surgical or post-prosthetic implant imaging. Right? There's kind of three phases: before, during, and after, basically, for lack of better terms. And let's say an office had available to them traditional kind of digital sensors. For PA and bite wing, they had a pano, a digital pan ready, and they also had a cone beam CT, which could be collimated down to different sizes and ranges. Okay, and if someone was wanting to place a standard implant in a number 30 site, okay, so kind of walk through somebody what you feel would be great diagnostic tools to use, kind of before, during, and after, because I know there's different times that probably different ones would be recommended.
Well, a lot of it's going to be, to begin with, some of it is going to be dependent on the whole surgical procedure or implant placement procedures that you use. Do you use a CAD/CAM generated surgical guide? If you do, that's going to lock you into some prescriptions. Whereas if you're not, then sometimes you can get by with a smaller volume cone beam. I think that I would probably start with either the intraoral or the panoramic image to decide, okay, what is the root morphology? What's the average height from the alveolar crest to the mandibular canal? What kind of general space do I have? And then couple that with working models and where is your patient at with regards to the whole decision-making process. If everything's looking pretty good, and then do you have a really good beefy ridge, and are you going to be flapping your surgical access, or are you going to go in blind, flapless? That's going to dictate some of that. And then I think that, if everybody's on board, then I believe that that's an indicator for doing a cone beam. I do like cone beam, even on quote unquote straightforward single tooth implants. And the reason is that a lot of people have had orthodontia. And it is not uncommon for me to see teeth out of buccal and or lingual cortical plates. Well, if particularly if you're doing a flapless access and, all those teeth that you're using for alignment have been pushed out of the buccal plates for whatever reason, where is your implant going to go? It's not likely that it's going to go in the middle of the alveolus. I think that from a grafting point of view, you're going to get better visualization of the overall anatomy of the implant site. How deep is the sublingual gland fossa there, and is it a sharp concavity or is it a shallow concavity down in there? And then, of course, obviously the mandibular canal, how how far is it from the alveolar crest? How long of implants are you using? I kind of question whether we really need 13 millimeter implants plus in 99% of the instances. That's a lot of retention. I think there's some argument as to whether 9 is quite adequate, but that's going to be a dictator in there as well, as well as the overall diameter of the implant prosthesis that you're using. If you end up that you need a graft, osseous grafting of one form or another, then I would, without question, do it at a minimum a small volume cone beam after the graft has it quote unquote integrated to make sure that in fact has taken place. I have found, nice ridges where we've got just granulation tissue and no osseous structure for implant placement. And you're not going to be able to tell that difference with an intraoral, periapical, or a panoramic image for that matter. Once you're in the process surgically, then the intraoral PA is probably the imaging modality of choice, because I'm assuming you're talking about, the osteotomy site. Are you where you want to be? Are you to the depth that you want to be, and everything else? A cone beam wouldn't be indicated for a multitude of reasons. And then for the post-op, if you want to evaluate osseous integration, cone beam is not the modality of choice. The physics of cone beam are anybody that's taking cone beam images should understand the physics of how the image is constructed, because it's quite different than an intraoral or a panoramic image. And there are some artifacts that are of concern, one of which is beam hardening artifact. And you cannot evaluate osseous integration with cone beam CT because of beam hardening artifact. So the periapical is the imaging of choice. Unless you want to do a reverse torque, then that would be the ultimate, I think, on whether or not you're integrated. So, but when for the implants, particularly the 3D, is going to be determined on your protocols. Are you using CAD/CAM generated surgical guides? Because if you are, then you need a full arch CT in order for the surgical guide to be constructed in the first place. And then again, if you're doing your post-grafting imaging, ideally the small volume is the imaging modality of choice. However, again, if you're doing a CAD/CAM design, you may in fact need to be doing the full arch. So that's going to dictate some of, the imaging parameters that you use in that instance. Is that kind of going with where you were headed?
Yeah, absolutely. And that kind of sounds similar to the protocol I use. I just wanted to see if that made any sense to you. I typically do either a periapical full mouth or a pano and a PA and evaluate, do I have enough bone there, and is the patient wanting to move forward with the implant? And if both are yes, then I usually get a full arch 3D scan so that I can make a surgical guide for that with integrate my technology and make a lab fabricated surgical guide off of the cone beam image, and then do a intraoral PA during the surgeries for angulation for the screws and osteotomy sites, and then follow up with PA X-rays afterwards, because you get such a crisper definition of bone to implant integration, and you can see the individual threads and where the line exact depths are. So there is still a lot of scatter on that CT. I guess that beam hardening artifact.
Well, there's two. Principally, there's two. There's beam hardening artifact, and then there's scatter artifact, and they're both different, and both of them are negatively going to impact what you're looking at. The beam hardening is
what's the difference there, I guess?
Well, the scatter spray has those white streaks going all over the place, and effectively what it is, again, little more complicated, but effectively it's just photons bouncing off of the high density material, whether it's gutta percha or metal. It doesn't make any difference. It has to do with the density of the material, and then you get the star effect, if you will. And you know, as radiologists, we can kind of work around it sometimes, but it's less than ideal. Beam hardening is a little more complicated. Again, it has to do with a polyenergetic beam, but in a nutshell, you can think of it as your implant, for instance, absorbing all of the photons, and so on the other side, there aren't any photons. And so the computer has a void, and so you see these dark lines. Beam hardening artifact is oftentimes misinterpreted as vertical root cracks in endodontically treated teeth, for instance. So you're not going to see that implant osseous junction there with a cone beam, whereas, like you said, if you're seeing those sharp threads on your PA, you can also see a pretty good joint junction between the implant and the osseous structure. I mean, does that mean it's integrated? Obviously not. It puts you much closer to deciding whether or not you've got integration versus using a cone beam.
Sure.
Does that help?
Oh,
Does
yeah.
that make sense?
Yeah, absolutely. I think that kind of breaks it down for, the common practitioner here who is just looking, how can I get the best information and what am I looking at here? Because, if you've read any CTs and you see those endodontically treated teeth or other implants, regardless which system you have, there's going to be that scatter artifact and beam hardening on both of those. So that just comes with experience and reading those and determining, what exactly it is. And that's where you've got to have, different images to evaluate and different ways to use them.
Well, and that's true. The other thing is that when you're looking at a CT image, you can't forget that, number one, you're looking at submillimeter slices, and number two, you're looking at a three-dimensional reconstruction of, either in different planes, the coronal, sagittal, axial, or in the reconstruction. And so, when you see something in one view, for instance, the axial view, then you need to go to the coronals and or sagittals and see if you continue to see this issue. And then that's where the interpretation phase comes in. It's not just, oh, I see this is this. No, that's not the case. You've got to be a little bit cautious in doing that. It took me a while. The residency, the first year we do a lot of basic education. We've got a year's worth of radiation physics and radiation biology, along with a bunch of other stuff. And then beginning in the second year, we're sitting down with faculty and doing reports day in and day out. And as somebody that came from, the private practice side or the general dentistry side, it took a while for me to change my mindset going from 2D to 3D. That didn't happen overnight. I mean, there was a pretty good learning curve to readjust my thought processes. So I don't expect practitioners to just, look at a CT and say, oh, that's what this is. I'm going, probably not.
Yeah, it definitely takes a lot of experience. And I guess that brings me to another good question now. If somebody were to acquire a CT machine and wanted to use that, one, where could they go for training? And two, where could they ship those CTs out for someone to read them and or to and then kind of talk about some of the legal ramifications for, full head imaging and what's behind that also?
Well, I look at it in several different ways. We've got a recognized specialty in radiology, just like we have for endodontics and oral surgery, et cetera. If the practitioner feels that they can do an interpretation just like a molar endo to the same level as the endodontist or the radiologist, then have a good time. my first question is how is this helping you generate income? If it's taking up more of your time that would be better spent seeing another patient or doing some of the lab work that's important to you or something to that effect, then maybe doing the interpretation isn't cost effective for you. Some of the graduate programs have mini residencies, if you will. The American Association of Oral Maxillofacial Radiology has a 2-day course, usually in conjunction with their annual meeting. There's programs throughout the country where you can attend. Some of the manufacturers have them where you can attend a 1-day or a 2-day course, and it'll give you some of the very basic fundamentals of understanding CT and how to start going through the process of doing your interpretation. With regards to who to send them to, most of the universities that have a radiology program have a report writing service to go along with it, because that's how the residents do the reports. That's where they get them from. We've got beam readers with David Hatcher, and there's a multitude of us. I mean, I'm a beamer, so I do reports for them. Most of the dental schools that have radiologists those radiologists will also have a private practice affiliated with the school somehow. So what I tell practitioners, and I tell my students the same thing with regards to CT, I strongly encourage people to do their own report, but at the same time send it out for a read by a radiologist, and then compare the two and see if you how close you are with regards to the specialist versus your own interpretation of what you saw. There's some myths out there with regards to the practitioner's liability. Long story short, if an anatomical area is covered in the imaging or in the study, whoever took the image is legally liable for it. Now, you don't necessarily have to know what the problem is, but you have to know that there's a problem and then refer the patient appropriately. And if you're not willing to go through the entire volume from the very first frame to the very last frame, then, I think that you may be asking for potential problems in the future. Is it going to happen? In dentistry, we're pretty blessed, but it can happen. So, it's where's your comfort zone and how much time do you want to put into it? And is it the best way for you to spend your time?
Yeah,
does that help?
Yeah, no, that does. That's kind of right on. Now, you touched on a couple things there. A private practice and beam readers, and I know you may be involved with both. Let's just say, for example, either your practice or I know you do some work with beam readers also. Let's say I'm taking a CT, I want to send that out. Kind of walk me through a couple steps. One, how do you send it out? Two, how much would it cost the dentist, because that company bills the dentist? And then obviously I either pass that cost on to the patient, or is there a CDT code for that? Kind of walk me through that. I got a patient, I want to take a scan, I want to send it to beam readers or you privately. There's a bill. Can it be coded, and who covers what?
There are codes, and there are codes for whether you acquired the study and did your own report, or whether you acquired the study and then sent it out to somebody else for a report. Now, whether insurance covers it or not, I'm fortunate enough now that I don't have to deal with that, and I do not miss it.
No, yeah, that would be my dream too, is to get away from ever having to deal with insurance again.
Yeah, that was a stress point for me. With regards to how do you send it, probably the easiest thing would be to talk about, for instance, beam readers. They're going to have a website that's all secure and HIPAA compliant, et cetera. You will set up an account with them, and they will help you to go through the process of how to export your files. And I want come back to that, so don't let me forget. But then they will, you will upload that study. Then it will be assigned to one of the radiologists. They'll do the report. We try to do a 48-hour turnaround, but sometimes it's a little bit longer. Obviously, if it's an emergency situation, we'll try to get those accelerated if at all possible. Then the report, once it's done, and images can be put into the report, other information can be put into the report depending on what the principal function of the report is, then that report will be sent back to the practitioner, and the practitioner is directly billed. It is not practical for report writing services or the radiologist to be billing the patients because we've never seen the patient or anything else. The other thing is that from a legal point of view, we're doing this on prescription by the referring dentist. So technically, we're working for you, and indirectly, we're working for the patient, if that makes sense. So even though we still have a direct responsibility to the patient, we also have our primary responsibility towards you. So, and then when you export the data set, this is something that I think practitioners, part of it's going to be dependent on the cone beam machine that you have. But I think that it's important that you understand how to save and export all of your files in DICOM format. And DICOM is Digital Information and Communications in Medicine, and it's a standardized format. And this is all going to be dependent on, like I said, the machine that you have and the software that comes with your machine. Some will save all the studies in both a proprietary format and a DICOM format, or some will save only in a proprietary format. The problem with that is that if you end up changing machines and or software, you will not be able to open them unless you maintain that software package. Whereas in DICOM standard format, you can open it with any third-party DICOM compliant software. So for the radiologists, we're going to have a couple of software packages that we use on a routine basis. And that's not to say that the software that comes with any of these machines is inferior. Quite the contrary. They're all quite good. But we can't learn 10, 15, 20 different softwares and then be efficient in our interpretive reports. So we're gonna scale it down to just a couple that are going to be geared more towards a production format, specifically for radiology versus principally a general dentist. Okay, I mean, this is our version of a crown prep, for instance. If we're not efficient at how we're doing it, we aren't going to be profitable because there's not that much margin on a $100 fee for a report. So it takes time. We've got to be as efficient as we possibly can. So if you export it in a DICOM format, it's going to go out to a radiologist. The radiologist is going to review it, put in there the information that you're principally looking for, along with anything else that's involved in the entire study, whether it's a 6 centimeter by 6 centimeter study or if it's a 15 by 20 centimeter study. We are going to look at the entire study from start to finish. And then the report will come back to you with, number one, our findings, and then our impressions and our recommendations, as to what may or may not be an issue. Does that kind of answer what you were looking for?
Yeah, that nails it down. So I know we're coming up on, our time period here, but what I want to do is give you a chance to close out with maybe kind of two things here. One would be, if somebody wanted more resources, either on training or information, where would you point them out to? And what's one of your last tips that you would give a general dentist or an implant surgeon of any kind of any other take home that we haven't covered yet?
The resources, the manufacturers have, and or the suppliers are developing more and more resources for the practitioners. So that's one. There are several good books out there. Dr. Shawneen Gonzalez has a very nice textbook for general dentists for cone beam. I think Dr. Dale Miles has one. The textbook with White and Farrow oral radiology has got 3 chapters in it, which are quite good. So there's a few books out there that are quite good. There's one thing that's really cool is the iPad. There are 3 or 4 different programs out there now for the iPad in particular that will help you with cone beam and anatomy and reviewing it, because there is going to be a learning curve for somebody. Like I said, it's a different mindset. So practice is what is going to be important. And probably one of the more important things that is of concern to all of us in radiology, and this is what I tell the students as well, is that as well as any of the practitioners that I work with on study clubs or what have you, if you're going to get into this technology, then it's incumbent upon you to understand the technology and how to use it appropriately. Unfortunately, we see one size fits all, and that's a concern, because if we're not careful, we may end up getting regulatory bodies involved that we don't want involved in our profession. So understand what the CT technology is, what it can and can't do, what the recommendations are from the different specialty organizations, the American Academy of Oral Maxillofacial Radiology. We've got the Implant group, oral surgery group, endodontic group, and the orthodontic group all have guidelines. And I would look at those guidelines because I think they're all very well done. And then prescribe the imaging modality of choice for you. Now, there's a lot of talk about ultra low dose and everything, and it's been tested well with phantoms, but it's not always ideal with in vivo with your patient. So why are you taking the CT? If you want detail, ultra low dose is not going to give you detail. So again, understand the machine, understand the different studies that are available to you with that machine, and then go from there. The other misconception that I want to eliminate is that a panoramic reconstruction from a cone beam CT is a replacement for a panoramic image. They are very different. It will give you a gross overview, but it will not give a reconstruction will not give you the level of detail that a panoramic image will give you. If you want a panoramic machine, buy a panoramic machine. If you need a cone beam machine, buy a cone beam machine. And there are some now that will do 2D and 3D, but 2D and 3D are just that. They're different. They're not the same. Hopefully that will help you and your listeners.
Yeah, I think that will. I think those are all good points, and I know there's a lot to take in, and we can't cover it all in just under an hour.
God.
But I just wanted to talk about some topics and get some awareness out, and then so that way people can kind of dig up their own research and kind of see what they need to do. But just kind of highlighting some of the top points here so that we can give people more to think about and more to chew about, so they can go do their learning on their own. So.
Oh, sure. It's a big purchase. You've got $100,000 machine. You want to make sure that your ROI is a value. Spending $100K and then not getting your money back on it from either directly or indirectly is probably not a prudent business decision.
Sure. and you always got to look at that, as you know. Unfortunately, you got to look at the business and the health of your patients first, and then think about will these two go together? So that's always good.
Yeah, well, the health of your patients are going to fail if you're out of business.
Absolutely, absolutely. Well, Dr. Walker, I appreciate your time today. I know it's valuable, and so I appreciate you spending it with me. And If anybody wants to
It's
get
been
a
my
hold,
pleasure, Phil.
if anybody wants to get a hold of you, where could they get a hold of you?
Creighton University School of Dentistry. So I am there full time. So that's my primary deal. So it's just Tim Walker at Creighton. It's creighton.edu.
Okay. Well, thank you for your time today. And
Thank you.
If
I
anybody
appreciate
get going down the road further with this podcast and we keep going, I'll maybe circle back with you and we can go deeper in some of those topics.
Okay. That'd be my pleasure.
Okay. Well, thank you so much.
Thank you.